I would like to invite Dr. Soumitra Ghosh from Kolkata. He is a professor in Head Department of Medicine, Medical College, Kolkata, and he is the Vice President, All India Association of Advancing Research in Obesity. He is also specialist certification of obesity in professional education. Over to you.
So, respected chairpersons, my dear colleagues, my teachers, seniors, and junior practitioners, I'm extremely thankful to the organizers for giving me this opportunity to talk on this most burning problem of the globe today, and that is the obesity and heart failure. What is the dawn of the new age? So, it is almost like the story of Arjuna, who is targeting one thing, just looking at the shadow of it. It is a goal to treat heart failure, but we are targeting obesity. That is the most beautiful system. And obesity is the perfect storm of the heart failure, the latest pandemic of the intertwined together, this heart failure and this obesity. And as we all know that the obesity has dramatically increased 4 times in last 4 decades, significant. 39% people are obese and 13%, 39% are overweight and 13% are obese. Many of them are having CV, disease, and that leading to heart failure. Exponential rise of the heart failure, but 1 billion particular people are suffering from this, and many of them, one-fourth of them are having obesity, and it is projected that the US alone will have a significant number of these heart failure patients, and it is almost double the number of just 10 years back. And if you look into this graph, you will see that regarding this vascular affection of this cardiovascular disease, stroke, or this coronary artery disease, heart failure is exponentially increasing with this BMI change. It is disproportionate. So in Framingham study, there is a twofold higher risk of development of heart failure compared to normal weight individuals, independent of the other risk factors. And for each 1 unit increase in the BMI is significant rise in the heart failure cases, 5 to 8% in men and women. And as you can see, in any group of people with rising BMI, the number of these heart failure cases just increase significantly, both men and women. If they are older, then with this rising curve in this BMI, this number of these heart failure cases increase exponentially. And as you all know that the heart failure is all not the same. There is actually 3 types depending on these echocardiographic findings. Reserved ejection fraction means more than 50% is there. Reduced ejection fraction means less than 40% is there. And in between the mid-range or mildly reduced 40 to 50%. So what type of heart failure is increasing in obesity? This heart failure with preserved ejection fraction. It is not all type. All type may be there, but it is actually this curve you can see. The preserved ejection fraction is increasing fast, very fast with the rising BMI. More than 50% of the heart failure today in the world is the preserved ejection fraction, and 80% of them are obese. And obesity is strongly associated with the development of preserved ejection fraction heart failure. Global prevalence is increasing while the reduced ejection fraction are declining or relatively stable. 20 years back, it was quite, unnatural to find a young person with this heart failure with preserved ejection fraction. But you will now find plenty of people in their 30s, 40s that are coming with this heart failure because younger people are mostly obese and having this kind of failure. So what is the pathophysiology behind it? It is a combination of the structural, functional, metabolic, and neurohormonal. All together, there are various things. But the most important thing is this visceral and the epicardial adiposity, which is changing a structural ventricular remodeling, systemic inflammation, and it is being added by this fibrillation, obstructive sleep apnea, and it is to be found that is a natriuretic peptide which eliminates sodium and water. They are actually less in obesity because of these many metabolic changes, and other comorbidities also contribute to this arterial disease. So enhanced inflammation, increased reactive oxygen species, alteration in the adipokine secretion, and insulin resistance. But these paracardiac adipose tissue compress the heart, impairing feeling, reduce secretion of the natriuretic peptide due to decrease in the chamber distension. So natriuretic peptide is actually proportionate to the chamber distension. As you can see, this CT scan cross, that you will find the heart is completely encompassed by the layer of adipose tissue, both in the epicardial part and around the pericardium, that is in short called the paracardiac fat. And these kind of things are giving rise to inflammation and a mechanical obstruction. So in our clinic study, you have seen that the diastolic dysfunction, which leads to this preserved ejection fraction heart failure, the odds ratio was almost 10 times higher in those patients with increased epicardial fat. So these ectopic paracardiac fat, epicardial and the pericardial, they decrease myocardial contractility and relaxation, impair circulation, release inflammatory cytokines, they increase the chamber stiffness, diastolic dysfunction and the left atrial dilatation, and giving rise to other kind of fibrillation. As you can see, this impact of obesity on the cardiovascular system are manifold. It can increase CV risk factors, atherosclerosis, heart failure, arrhythmia, thromboembolism, and the valvular disease. But specifically, this heart failure is disproportionately higher in these particular people with preserved ejection fraction. So this is to be noted that this preserved ejection fraction heart failure is not a disease of the heart per se. It is the effect of the obesity on the heart. As you can see, as you see the heart failure, we always think that the heart is the culprit organ, but obesity is the culprit here, giving rise to this affecting the multiple organ system as well as the heart. Heart is one of the affected organs here in the systemic disease. It's not an accident that so many HP, this heart failure with preserved ejection fraction is increasing. It's not a simple comorbidity. It is the root cause of this heart failure, and that realization has changed the whole thing right now. Pump function of the heart is actually normal, but patients develop heart failure. The symptoms, shortness of breath, effort intolerance, fatigue, swelling, all are there. So obesity drives the development of this type of heart failure triggered by metabolic and inflammatory response. But all these, measures taken for this reduced ejection fraction, they are not effective in this preserved ejection fraction. And lesser mortality in this preserved ejection fraction is also there, but the hospitalization rate is higher. You can see this hospitalization rate, symptom burden, and is higher in this preserved ejection fraction. The quality of life is actually very less here. But two facts behind this dawn of this new era for treating heart failure with preserved ejection fraction for obesity is that the obesity is the root cause. It is not a simple comorbidity, and we must treat this obesity first. And availability of the efficacious second generation anti-obesity drug. These two factors has ushered in this new era. As you can just see this meta-analysis of 19 studies comprising 4.5 lakh people. This published in the European Journal of Preventive Cardiology in 2023 August. The effect of weight loss on the heart failure. This study says that weight loss improves the quality of life, cardiac function, and exercise capacity. Is decreased this rehospitalization in the long term, but did not reduce the risk of short-term hospitalization. Unintentional weight loss was associated with higher mortality, and weight loss did not reduce mortality. Medication or exercise or lifestyle, etc., was not significantly associated with the risk of death. But surprisingly, weight loss from the bariatric surgery subgroup decreased the risk of death. Point to be noted. And this Journal of American College of Cardiology in 2024 January, they also observed that weight loss, especially by bariatric surgery, is associated with the lower rate of incident heart failure, and weight loss is associated with the improved symptom burden in patients with preserved ejection fraction. So two factors determine the heart failure outcomes with weight loss obesity. Particularly point to be noted the extent or the percent of weight loss and how the weight is lost, whether it is desired or undesired. You'll have to differentiate, because for every target related to diabetes, this obesity, you'll have to set a percent, weight loss as a target. You cannot expect everything with the minimal loss of 5% or so. So for this cardiometabolic benefit, you need the maximum CVD risk reduction, you need to 20% reduction or so. You can see these targets are different. So percent weight loss are all different. To reduce this, heart failure with preserved ejection fraction, it is almost 10 to 20% or even more than 20%. So target has to be reached higher. So what this second generation anti-obesity drug, they are very efficacious. They can produce more than 10% weight loss. They can be sustainable, and more than 50% patients can achieve this for at least more than 15% weight loss. So this first generation was there. Now the second generation drug, which are efficacious, sustainable, they are the semaglutide injectile and the tirzepatide. And as you can see that all these measures for this obesity control on the surgical side could reduce 25 to 30%. And these tirzepatide can reduce 17.8%, and the semaglutide, they are really comparable, more than 10%, 12.5%. and they have changed this whole thing. Two group of drugs have shown improved outcome in this preserved ejection fraction. Number one, SGLT2 inhibitors and this incretin in obesity. So several trials are there. The Emperor preserved trial for EMPA, Deliver trial for this DAPA, incretins for this STEP FREF trial for non-diabetic as well as diabetic for SEMA, and the Summit trial for the tirzepatide. Let's have a look into all these things. SGLT in this preserved ejection fraction heart failure is the wonder drug of this century, this SGLT2. These are having a great change in this heart failure. And EMPA in this heart failure in the preserved is published in 2021 NEJM with this 415 patients, and they decreased this hospitalization and the composite of cardiovascular death and number of hospitalizations, etc., significantly. And effect of EMPLA with consistent in patients even with that without diabetes. And you can see the curve, it is significantly different than this. EMPA can decrease this rate of hospitalization compared to the placebo. DAPA also is significant in this worsening heart failure prevention as well as the cardiovascular death prevention, and it is published in 2022. All are recent studies published in in NEJM. And you can see this curve is also differentiating and very promising both this composite death of this cardiovascular cause and the worsening of the heart failure. And they can change this thing in a novel mechanism by different ways. And our next speaker will discuss about this. But what these incretins, particularly these GLP-1 receptor agonists, are doing these things. SEMA have this safe semaglutide treatment effect in people with obesity, particularly in these patients with heart failure, preserved ejection fraction. And they have done these patients with obese patients with class 2 of this heart association classification. More than 30 BMI were taken into this, and this study was published in 2023 August. So this Kansas City cardiomyopathy questionnaire clinical trial score was significantly changed. Change in the 6-minute walk distance to exercise ability and this quality of life, they are all changed. Change in the CRP, the inflammation. We all know this Kansas City cardiomyopathy questionnaire clinical summary score and the 6-minute walk distance are two important parameters which are incorporated in these heart failure studies as the patient reported outcomes. And there are 4 domains, and all 4 domains are captured here. You can see a big change in this Kansas City quality of life score in this STEP style, and you can see this change also in this body weight. Significant change in this body weight is there, 10.7% compared to the placebo, and this STEP also decreased this 6-minute walk distance was significantly different. So quality of life and exercise tolerance, and the inflammation also comes down significantly. So this stratified win ratio was significant, hierarchical composite endpoint of these all different parameters. And this SEMA trial showed a large reduction in the weight, greater improvement in quality of life, greater improvement in exercise capacity, greater reduction in inflammation, and benefit observed in all BMI categories. Now this SEMA, with this people analysis, the pooled analysis showed the NT-proBNP level was reduced, significant improvement in the heart-related symptoms, and this mean exercise in this Kansas City questionnaire and this walk distance all are improved and compared with these other studies. So despite the fact this NT-proBNP is decreased in these heart failure studies, it was shown that with this treatment, so it actually shows that it is not the effect of the weight loss alone, it is the heart failure which has improved. So other parameters are supportive. So benefits seen in the SEMA were not simply due to weight loss, changes of the other parameters of heart failure supports this group. So pathophysiological process underlying this heart failure has been addressed by the SEMA. Now this tirzepatide, the dual incretin, they have a composite or adjudicated death from the CV and the worsening heart failure. Both were improved, and you can see these changes in the placebo group. They are significantly better, and this quality of life change with this tirzepatide was significantly higher, and all these key secondary endpoints, they were improved. All-cause mortality, the Kansas City questionnaire, 6-minute walk distance, blood pressure, percent change in this HSCRP, and mean weight loss, all were significantly improved. So treatment with tirzepatide led to a lower risk of a composite of death from the cardiovascular cause and worsening of heart failure than placebo, improved health status in patients with heart failure and preserved ejection fraction and obesity. So benefits of incretins beyond weight loss we could find, and significant weight loss, decrease in the pericardiac adipose tissue, improvement in the insulin sensitivity, and this enhancement in the cardiac energy efficiency, lower NT-proBNP, inflammatory parameters, fibrosis, etc. Tirzepatide reduced the LV mass and the pericardiac adipose tissue. How could you see the summit, this cardiac MRI study? This is a subset of study. It was done, this cardiac MRI at the outset and after 52 weeks. And 106 patients completed and they could be assessed. And we have seen this LV mass decreased almost by 11 grams, change in the LV mass paralleled with weight loss, and the pericardiac adipose tissue decreased by 45 ml in this group corrected compared to placebo. And the conclusion was that tirzepatide therapy in obesity-related heart failure with preserved ejection fraction led to a reduced LV mass and the pericardiac adipose tissue. This is the basic problem which is leading to this heart failure. Heart is not the culprit organ, and these physiological changes contribute to reduction in the heart failure trial, the events seen in the Summit trial. Now, the big problem is this concept among the physicians and the diabetologists that there is a obesity paradox. They think that the obesity patients are better protected in the cardiovascular outcome or even this heart failure and this coronary artery disease. But actually it is a faulty study design, and it is evidence such as the body composition is important, it is not the BMI. And this waist size ratio has markedly changed the story in a different way, and this European Society of Cardiology has already given this statement clearly in 2023 March that this obesity paradox does not exist, and weight to height ratio is a better indicator of outcome in patient heart failure than BMI. So target the root cause of obesity to treat heart failure. That is the basic thing. It is just the dawn of new era to tame this, heart failure with preserved ejection fraction pandemic, and this is which is actually just ruining this society, ruining the civilization. The improvement in this medical field in the last few decades are being completely reversed by this obesity and the heart failure and the quality of life. So what are the take home points? So obesity unleashes the current pandemic of this heart failure with preserved ejection fraction by mechanical, paracrine and endocrine effects of the pericardiac ectopic tissue. This is the most important thing. And pathogenic mechanism of the heart failure with ejection is different from these reduced ejection fraction subtype. And there are challenges in the diagnosing of this heart failure in persons with obesity for various reasons. NT-proBNP is decreased, this echocardiographic window is sometimes difficult, JBP may be difficult, auscultating heart, and these H2, pulmonary arterial hypertension, all are difficult. Drugs and devices which improves the outcome in this reduced ejection fraction have no or minimal benefit in the preserved ejection fraction related to obesity. Earlier studies showed that the lifestyle did not improve the outcome of this preserved ejection subset. Significant weight loss by the bariatric surgery improved symptomatic and the mortality outcomes. To summarize, only two categories of drugs improve outcome in heart failure with preserved ejection fraction: the SGLT2 inhibitors and the incretins. Semaglutide and tirzepatide assert the dawn of the new era for the heart failure with preserved ejection fraction in obesity. Most likely mechanism of benefit of these two incretins is the extent of weight loss, percent weight loss, almost comparable with the bariatric surgery, and favorable body composition, lower fat mass and the higher lean mass, rather than body weight, provides morbidity and mortality benefit in the heart failure with preserved ejection fraction in obesity. And body composition and how the weight is lost explain the confusion surrounding this obesity paradox. So heart failure does not always mean that heart is the culprit organ, the heart is weak. Heart is stronger here. Just remove the outside factors which is compelling the heart to perform poorer. So heart failure with preserved ejection fraction in obesity due to obesity induced changes in the heart. To conclude, this heart failure with preserved ejection fraction is burgeoning but silent epidemic that is most commonly associated with obesity after years of therapeutic nihilism. When we had nothing to offer our patients with heart failure with preserved ejection fraction beyond diuretics and comorbidity management, there are two proven effective pharmacological options now: targeting body weight and body composition through lifestyle, pharmacological and metabolic surgery addresses this modern challenge. So newer insights and therapeutic interventions in obesity have begun the new era of managing heart failure with preserved ejection fraction related to obesity with efficacious drugs Now we look forward to the future with more research to address this problem with renewed hope. Thank you very much for your patient hearing.